Hi, everyone. Thank you all for joining. Today, we have the great honor and privilege of having Dr. Estelamari Rodriguez with us. Dr. Rodriguez is an Associate Director of Community Outreach and the co-lead of the Thoracic Site Disease Group of the NCI-designated Sylvester Comprehensive Cancer Center at the University of Miami Miller School of Medicine. She has a special interest in the early detection of lung cancer and supervises the lung cancer screening program at the Sylvester Comprehensive Cancer Center. She's also an active member of the Experimental Therapeutics Program. Dr. Rodriguez received her bachelor's degree from Columbia College and her medical degree from SUNY Downstate College of Medicine. She completed her internal medicine residency at Columbia University's New York Presbyterian Hospital and her medical oncology fellowship at the University of Pennsylvania. Dr. Rodriguez also has a master's degree in public health from the Universidad Autónoma de Madrid, Spain, and she's given numerous lectures as an invited speaker on issues related to lung cancer and healthcare disparities. Dr. Rodriguez, thank you so much for your time and your willingness to be here with us. We're so excited to have you.
Thank you for the invitation. Looking forward to our discussion today.
Absolutely. So to introduce myself and my team, my name is Priyanka Senthil, and with me I have Drake Long, and we're part of the American Lung Cancer Screening Initiative, or ALCSI for short. And we would like to take a few minutes to share about our organization, as well as introduce lung cancer and lung cancer screening. ALCSI is a 501c3 nonprofit that works to raise awareness about lung cancer screening. And we're a team of over 200 students and doctors located across the United States. We do the work that we do because lung cancer is the deadliest cancer in the world, causing more deaths than breast, prostate, and colon cancers combined. Lung cancer causes about 380 deaths per day in the US alone. Lung cancer is very fatal because currently many patients are being diagnosed at a late stage when the cancer has grown and spread to other parts of the body. Lung cancer screening is an effective imaging technique that can be used to screen for lung cancer and has been shown to catch lung cancers early. However, less than 6% of people at high risk for lung cancer are currently getting screened. The screening rate for lung cancer is much lower than the screening rates for breast, cervical, and colon cancers, which are about 70%. We believe educating people about lung cancer screening is one of the most important and effective ways to increase the lung cancer screening rate for populations that would benefit from lung cancer screening. So far, we've given over 250 presentations on lung cancer screening to universities, hospitals, medical schools, and organizations around the US, as well as India, Canada, Brazil, and Mexico, reaching over 10,000 people. And over the last year, we worked with over 340 mayors from every single US state to issue proclamations recognizing November as the National Lung Cancer Awareness Month. We've also had the opportunity to work with several leaders at the state level, including multiple mayors, Arizona State Senator Leila Alston, who's a lung cancer survivor, Pennsylvania Governor Tom Wolf, and Lieutenant Governor of Colorado Diane Primavera to issue public service announcements, emphasizing the importance of lung cancer screening. In addition to our education, outreach, and advocacy efforts, we recently started this podcast series to share the personal side of lung cancer and provide a platform for lung cancer survivors and experts to share their stories. ALCSI worked with US Congress members and senators to draft and advocate for the first ever House and Senate resolution recognizing the importance of the early detection of lung cancer screening. And in December 2022, the US Senate passed a bipartisan resolution for the third year in a row, designating November 2022 as National Lung Cancer Awareness Month and expressing support for the early detection and treatment of lung cancer. Senate Resolution 863 expands on previous resolutions by emphasizing the need for efforts to increase awareness of screening among veterans, women, and racial minorities. ALCSI also actively worked with Representative Brendan Boyle and Senator Tina Smith to draft and advocate for Catherine's Law for Lung Cancer Early Detection and Survival Act of 2021. So lastly, we want to talk a little bit about lung cancer screening. Lung cancer screening is done using a low-dose computed tomography scan, and this scan uses low radiation doses, is pain-free, and takes less than 5 minutes to complete. The United States Preventive Services Task Force, also known as the USPSTF, sets guidelines for who should be screened for lung cancer. And right now, they recommend that people between the ages of 50 and 80 who have a 20-pack year smoking history or more, and who are currently smoking or have quit within the past 15 years, get annual low-dose CT scans. 1 pack year is defined as smoking on average 1 pack a day for 1 year, and therefore 20 pack years can be met in a multitude of ways, including smoking 1 pack a day for 20 years or smoking 2 packs a day for 10 years, for example. If you know anyone who might be eligible for lung cancer screening based on the criteria we just discussed, please encourage them to take our lung cancer screening eligibility assessment so that they can learn whether they are eligible and have the opportunity to contact our team at ALCSI to guide them through the screening process. And finally, we want to highlight that there are other risk factors for lung cancer in addition to smoking, such as exposure to asbestos, a family history of lung cancer, COPD, and previous radiation therapy to the lungs. We believe that it is so important that we recognize these additional risk factors because a large number of people in the United States who have never smoked still get lung cancer. So thank you all for taking the time to listen to that quick introduction to lung cancer and lung cancer screening. Without further ado, we can jump right into the podcast. We have a few questions for Dr. Rodriguez, but we will also have a Q&A session at the end where you all can submit any questions you have for her. So Dr. Rodriguez, thank you again for your time. And our first question for you is, could you please tell us what a day in your life looks like?
So thank you for that question. So I am a thoracic oncologist. So my regular day is seeing patients that have been diagnosed with lung cancer. And that's why when you meet patients with lung cancer and 3/4 of them have presented with metastatic disease, the first question I ask myself is, could we have avoided this? Could we have, diagnosed this early and offer this patient curative surgery? And over the last, since I graduated from fellowship, like 15 to 20 years, we have really transformed the treatment for lung cancer. So we definitely have more lung cancer survivors, but many of the patients that are now benefiting from treatment, immunotherapy, targeted therapy, they still die of their disease. So lung cancer screening, which is something that we have known about for a long time, and is so underutilized, it really has the possibility of really getting to more real cures, because we will be able to catch lung cancer at its curable stage. So that's something that we would like to see our clinics change. But my job is to treat patients once they have been diagnosed. Once they already have seen a pulmonologist, they already have had a biopsy, they've been identified. And unfortunately, over the last 2 years after COVID, and all screening programs have trended down because people's attentions were elsewhere and many of our programs got closed. We are seeing now a little bit more of a rise of more advanced diagnosis. I think that it's been more dramatic changes in mammogram, colonoscopy. Lung cancer screening has been so underutilized in Florida. It's only about 3% of eligible Floridians that get screened in average. So we didn't really lower more than that because the bar is so low, but we definitely want to get people to change the conversation about lung cancer. And that's the other part of my job. So my job during the day is seeing patients with lung cancer, treating them, giving the best treatment options. And I work with a multidisciplinary team of surgeons, radiation oncologists, imaging pulmonologists, interventional pulmonologists, and we all try to, find the best treatment for this patient. But on my academic time, because I'm on academic time in working in an academic center, so one of my research interests is trying to find ways to increase our lung cancer screening program in our Hispanic population. So that's why I do the rest of the week.
So as an associate director of community outreach and co-lead of the Thoracic Site Disease Group at UMiami, could you please tell us a little bit about your lung cancer screening program at UMiami?
Yeah, so I'm glad you mentioned the word outreach, because I think that for us to change the conversation about lung cancer screening, we have to stop devising these beautiful programs with beautiful machines and just kind of wait for people to come to us. We really have to engage the community, kind of change the conversation. And that's the work that takes a long time. And, and it works in many different facets. But our program has been around since the National Lung Cancer Screening Trial was launched in 2011. So we've been part of the process. We enroll patients in that trial. We enroll patients in the ALCSI trial. But it wasn't until insurance companies in Florida started covering lung cancer screening and it was formally approved that we were able to grow our program. And our program has initially, because it grew as a research idea, it was small. And then over the last, I guess we've been doing screenings for about 12 years. But I will say it's been in the last 6 years when we really hire a navigator and became part of the ACR registry that we were able to really grow. And part of growing, part of what outreach is, so I do a lot of work going in the community. So I'll give you an example. So I'm in the board of the American Cancer Society, and the American Cancer Society, which I support greatly, has given a lot of money and a lot of great work for other screenings. And lung cancer kind of always comes lower down in their list of priorities, but it's also because they don't have a lot of thoracic oncologists and pulmonologists who are involved in their enterprise. So we all have to get involved in foundations that are funding research and screening. So that's one of the things I do. So I get involved with our community, trying to raise awareness and make sure that if money can be used for lung cancer screening initiatives that is used. And then we do things like during Lung Cancer Awareness Month, we have informational tables, and we have partnered with community-based organizations like Break the Cycle, which is a group of African-American cyclists that meet in areas that are underserved in Miami downtown area, and they feed the homeless. And it's a great concept. They ride their bike, so they're doing an exercise, they feed the homeless, and then they communicate a message. So that's something that we have done with them for different things. But I think for lung cancer specifically screening, what they're doing, which is really going out there to communities that need and kind of cycling into communities that we don't go to as physicians, is key. So we have to engage community navigators and people that are in the community that have been affected by lung cancer in the conversation. So that's what outreach is about. So we have a program where people order, and we have optimized our program to get as many patients that we see in our clinics to get referred for screening. But also another part of this is to really go out there and talk about lung cancer screening with people where they are, wherever they are, like, in a barbershop, talk about someone who got diagnosed, and talk to people in their church. So we kind of have to engage in many levels.
Yeah, that's wonderful. Thank you so much, Dr. Rodriguez, for sharing. First of all, we want to thank you for all of the work that you're doing, because I think it's just so important, and it's wonderful to hear how the program has expanded in recent years. And you had mentioned that, lung cancer is one of the least funded cancers, and that is the case across the board. And I think outreach and efforts to lobby for greater fundraising for lung cancer research and just screening programs is really important, and being able to implement resources for patients, such as patient navigators, to really help increase uptake of lung cancer screening. So that's just so wonderful to hear. And our next question is, could you tell us a little bit about what you've learned while helping to lead the program? So it would be wonderful if you could talk about, what you think has gone really well in terms of building the program, as well as if you could talk about some challenges that you faced, or that the program has faced, and maybe what you would have done differently.
I don't know if I can share, but I will describe to you what we have first learned. So we have learned that our community is different than the National Lung Cancer Screening Trial. So the National Lung Cancer Screening Trial, which is the largest screening trial that we have funded with tax money, that took so long to implement, but it was well done. But it really was very disproportionate in the amount of high-risk smokers that would enroll. So it only included 1.8% Hispanics. And that tells you that that trial didn't really take us where we needed to go for my community. So we didn't learn from that trial about the challenges of adherence. We didn't learn about how to best capture patients that were Hispanics and what the challenges were. And the same thing for African Americans, like the National Lung Cancer Screening Trial had 4.5% African Americans, where in our community, we have 15% in the patients that we screen. So we have looked first about who are our patients. So we serve a largely Hispanic, Spanish-speaking population, which the rest of the country is gonna soon also serve, because it's the largest ethnic group. So when we look at our patients that we have screened, 47% of them are Hispanics, compared to 1.8% of the patients in the National Lung Cancer Screening Trial. So when we look at the differences, we see that Hispanics have a lower smoking history. So that tells you from the get-go that many Hispanics who are at risk will be not included in the older trials. And we know now with the new guidelines that the smoking history has decreased, and the age has decreased to 50, and the smoking history to 20 pack years. Actually, one of the groups that really benefits, besides African Americans, is Hispanics. So like the amount of Hispanics, the eligibility criteria will go up by almost 78% among Hispanics. So that tells you that we were missing all these people for all these years, and we already were missing them because no one was getting screened. And I think understanding how our community feels about the stigma of cigarettes, and who Hispanics are a very diverse group. And we're lucky enough in Miami that we actually don't have a very diverse Hispanic community. So we have very recent immigrants from Cuba who may have a higher smoking history. We may have people that have been established, third, fourth generation Hispanics who live here. We also have Venezuelans, Puerto Ricans, Dominican. So there's a lot of different Caribbean, there's a lot of different types of community that may feel about it differently and maybe have different levels of acculturation. And that is something that we have to understand, and we have learned to understand when we approach our patients about screening, that patients are not very, first of all, we're going to get less Hispanics to agree to tell us that they're smoking because they actually have a less smoking history than other groups, but also they're not going to feel as comfortable to kind of share that information. So one of the things that has worked for us, and we're lucky enough to have a workforce that is culturally more competent because they're from the community. So we have kind of nudge questions for our, when we enter patients in our system, we try to get some kind of approach with the patient where they can feel comfortable sharing their smoking history, because the smoking history then triggers all these signals. And we have, like many centers, we have created these best practice advisories that kind of give you alerts in your electronic medical record that this patient is a candidate for screening. And we try that, and many centers have also found that those are not very helpful because doctors just kind of ignore these alerts. But I still think it's important to classify patients that will be screened, so at least you can follow them and find ways to intervene. So we recently did this with the American Cancer Society. We did a quality improvement project, and I will mention it because we learned a lot about the challenges. So we spent a whole year trying to collect data of who was being missed. And that was the hardest thing, because we learned that many patients were not giving their smoking history, and the data was all over the place. So it took us like a long time to kind of figure out who are actually the patients that would have been screened in 2021. So we got a baseline. So we were happy to find out that for our whole institution, our baseline screening was around close to 20%. So we were not doing that poorly for patients that are already in our system. And then we spent a whole year trying to do all of these multi-level interventions, from increasing the navigator time to having a social media campaign to having these outreach opportunities that I described, to optimizing the electronic medical record. So our patients that are using our portals, the patient portals, part of the patient portal, they have a health maintenance gap, where patients get this, it tells them you're due for a colonoscopy, you're due for a mammogram. And we were kind of shocked to find out that screening was not even part of the list of things that patients were getting warned about. And that just goes to show you how even in an institution like the University of Miami, these things get missed because cervical cancer, colorectal cancer, breast cancer get a lot of funding, they kind of come to the front, and then lung cancer screening kind of gets seen as like an afterthought in many discussions. So we thought it was important that patients were at least getting their own direct warning about screening, so at least they could engage their physicians in that conversation. So we were able to do that. But after all of that, we opened some satellite clinics to do screening on Saturdays. I mean, we tried different things, and we showed an improvement, but it was only 5%. So it just goes to show you that a lot of effort can take place. You can't do one intervention, you have to do many interventions. And then you have to find ways for these interventions to kind of keep going. Because if you fund something like a social media campaign, we did one last year, and we saw the amount of people that were going on our website, the amount of people that were calling for screening went up. But then once the media campaign died out, those increased interest went away. So it's a constant, so what we have learned is that you have to target this in many different ways. You have to educate physicians. So we spend time talking to our trainees, family practice doctors who are training, and really the people who are seeing the primary care. The primary care clinics are a big place where you can capture screening. So we kind of re-engage them in the discussion, reminding them about the new screening guidelines, and kind of share best practices about how you can get a patient to say yes to the screening. So that is an effort that I think will continue to pay off, because once you have those conversations, physicians will make that part of their habit. You just have to keep having them. I think the thing that always helps, and I will tell you, last year one of our navigators went on maternity leave, and the time that she was away, our lung cancer screening rate went down by 5%. So it just goes to show you that some of these services are very much people interface. Like, you kind of have to have people engage with people You need navigators to engage patients, to adhere to the second screening, to come in, to like answer questions, and especially a lot of the fears that are around being diagnosed with lung cancer. So I think you kind of need the providers to provide the message. You need to collect the right smoking history. You need to have a constant message that it's in many different levels, either in the electronic medical record that the physician sees, that the electronic medical record patient photo that the patient sees. And then you also have to keep this going. You have to keep doing it. Like you can't just do it for 3 months. You have to keep doing it every year. You have to have a plan that, okay, this year we did this, and this is what worked, and it only got us like 5% more. Now next year, what do we learn worked, and what we can keep doing to make it grow. But I think of all the things that we have done, definitely the navigators by far are the biggest investment.
Wow, that was just so interesting. Thank you, Dr. Rodriguez. It was also really interesting to see how the racial/ethnic distribution differs for your program when compared to NLST. I think you highlighted some really key points in that the NLST has really been a landmark trial in helping to formulate the USPSTF lung cancer screening guidelines. But we, in terms of racial minorities, there's a very low representation of Hispanic individuals and African American individuals. And so because the USPSTF guidelines were, mainly focused and based off of the results of the NLST, studies have shown that even with the new expanded lung cancer screening guidelines, the new updated guidelines in 2021, as you had mentioned, there still exists a lot of racial and gender disparities. And you talked about how Hispanic populations are more likely to be diagnosed with lung cancer at younger ages. And so that might mean that potentially having different criteria for different racial groups might be the best way to ensure that we're screening all high-risk individuals in each of these populations, since a one-size-fits-all type of criteria approach might not be ideal when there's so many different when the epidemiology of lung cancer is different across the different racial groups. So I think that was a fantastic point that you brought up. And you also talked about needing multiple interventions, so using patient navigators, using electronic patient health records to alert doctors when a patient needs to get a lung cancer screening, or maybe when they're even eligible for lung cancer screening, needing to gather, first of all, the smoking history. And you had mentioned how a lot of patients weren't providing that information, and if they're not, then I think it's so important that we reflect on, how do we collect that information, or what are the barriers to collecting that information, really addressing that. So it's just so amazing to hear all of the interventions that you and your team have tried to put into place with this program, and seeing it grow. So yeah, thank you for sharing. It's really eye-opening to see.
Yeah, so you mentioned earlier about your efforts to increase screening and awareness in the Latinx community based on your previous trials and work. So could you please tell us the status or state of screening in the Latinx community, and what you're trying to hope to implement or try out this year to increase, I think what you said, the 5% increase in screening?
So I will kind of share with you that, Hispanics have different challenges. So in terms of lung cancer, so lung cancer is the #1 cause of death for males, and the second one for women. So we have more other competing needs in the Hispanic community, like heart disease and actually accidents. But when we look at, to answer the question about screening, you have to see how Hispanics are presenting with lung cancer. So I know that you won't be able to see my image if you're listening, but I did wanted to share that actually, Hispanics, when compared to other ethnic groups like whites and African Americans, actually present with less early stage disease. So they're 16% less likely to be diagnosed early, which already tells you that that's a group that we need to screen more, because why are they being presenting with less early stage disease? Now, what we find is that once they have insurance, which is a huge barrier for the Hispanic community, it's like one of the top uninsured, underinsured ethnic groups. Once people have insurance, they're equally likely to get surgery. So that has been shown in many centers. But the one thing that sometimes people ignore is that in the Hispanic community, there's a lot of denial of treatment. So, and this has also been described and needs to be addressed in the African-American community. So like patients are 26% less likely to not receive any treatment at all for lung cancer. So when I look at this kind of picture of how lung cancer presents in Hispanics, and I know that we're being diagnosed early less often, and when we present early stage or late stage, either the family or the patient, fatalism, you can call it many things, health insurance, they're less likely to receive effective treatment. So that really the intervention needs to be early stage disease. And that's where we really have a lot of work to do. So I think screening, again, becomes the obvious answer to that. Like, how do we change the tide? I think that, we haven't covered this, but the health insurance is one of the biggest challenges for us to get Hispanic screened. So we work with federally funded community health centers in our area, and they get a lot of grant money from the state for breast and cervical cancer initiatives, which is wonderful. But lung cancer, because I still feel that there's a lot of stigma, even from the funding perspective, this kind of free money for free screening doesn't get distributed as well. So many of the centers now have lung cancer screening month, and they'll give like $100 lung screening tests offered for free, which is great if you think that $100, people spend $100 in other things. But lung cancer screening is not a one-time intervention. Like many screening tests, it's not a one-time thing. Like you have to then have insurance to see a surgeon and get a biopsy and have someone look at this pulmonary nodule and follow it up. So health insurance is one of the biggest challenges for the Hispanic community, and especially where I live in Florida, where we have an expanded Medicaid. It's a big challenge. So that the patients that I talk about, that I see through my screening program, all of them have insurance, and it's challenging. The patients that I don't see because they don't have insurance and they get seen at Jackson Memorial Hospital, which is our publicly funded hospital, those patients, there's so many needs, and the system is, they have a screening program, but the challenges are many. And I think that we need to advocate for resources for underfunded, underinsured patients that need screening, because many of them are really the people who are in the workforce. I mean, we see them, these are the immigrants that are working the kitchens, and everything else that is being happening to move the city along is being done by people who don't have insurance, and many of them who qualify for screening. So I think that for the Hispanic community in particular, that is being diagnosed less often with early stage disease, interventions on screening will really impact mortality rates greatly. And I think the investments that we make to advocate for health insurance coverage, for Medicaid expansion in states that are not expanding, like Florida, is key. Because I think we'll see, and this has been shown overall for cancer care, that if you expand Medicaid, just that, you improve outcomes of cancer. So we need to do that for lung cancer, at least in Florida.
Yeah, absolutely. I definitely agree with that. As you had mentioned, there are a lot of programs, lung cancer screening programs, who are able to implement maybe some sort of assistance program for individuals who might need that extra financial support, and they're able to help them get that initial scan. But after that, if they're uninsured, then especially if there is a potentially suspicious finding on the scan, then they're going to need additional testing. They're going to need a biopsy and definitely follow-up testing in following years. And so without the expansion of insurance coverage, that becomes really hard. And so we're able to get patients the initial scan, but aren't able to help them afterwards. So I think that was a fantastic point there. And so one of your interests is understanding how to improve lung cancer screening messaging for the Hispanic population and other groups at high risk for lung cancer. And so through the advocacy efforts that we work on within ALCSI, we know that it is so critical to tailor lung cancer screening information to the specific population that we are either presenting to or outreaching to. And so could you share with us your work and ideas on this topic, and how best we can reach the Hispanic community and other racial minorities with lung cancer screening information?
So one of the things that we did about a year and a half ago is that we started looking at the use of social media by Hispanics, and it's actually really eye-opening. Like, US Hispanics on Instagram is in the millions, and they are bilingual, and they get messaging in English, 5.8 million people, 4.1 million people prefer Spanish. So when we also look at WhatsApp penetration, and this is interesting because use of uptake of social media kind of changes by age. So like, our very elderly patients in many ethnic groups, we don't really know how to use social media, but it turns out that many Hispanics who are elders, they have to get savvy at communicating by WhatsApp because this is the way they communicate with people back home where they come from in the Caribbean, South America. So we have found that there's actually more literacy than you expected. And when they have done surveys asking Hispanics how they receive information, so there's still a big percentage that uses print media, and that's actually bigger for Hispanics and other groups. So like newspapers and community papers are read by older men and older women all over Miami. But then social networks and social media it's actually utilized heavy. So we did this campaign where we partnered with a marketing firm, and marketing firms have a lot of information on people. So we actually asked these marketing firms to find people who were Hispanics, who were age 50 to 80, who were in our catchment area, who spoke English or Spanish and had a smoking history. So we couldn't get the specific smoking history, but we could get a smoking history. And then we were able to do a direct campaign where you get basically like banners of our screening program and kind of news of our screening program in your Facebook page, in your Instagram page. And with that campaign, we were able to do that right after COVID, because that's when we saw the biggest drop in our screening program. And we sent, let me tell you how many, we did that social media campaign with programmatic banners and platforms for Instagram. Then we did also a direct mail campaign because we know our community also uses print media. So we use postcards and 65,000 leads by email and 87,000 leads by postcards. And then we measure how many visits we had to our website and how many new referrals we got. And we saw a significant increase in a short amount of period. So like before the campaign, we had about 230 page views. After the campaign, we had about 8,800 page views, and people were spending about 2 minutes in the website, kind of moving around through our screening explanation and how to get screened and what it meant. So there is some kind of cost effectiveness of direct marketing, I think, for our Hispanic population. The problem with many of these interventions is that, of course, when you stop doing this, can you keep it up? So, but I think that's only part of the solution. So the other things that I do is that I think that, people are addicted to social media and TikTok. So we have done videos on TikTok on screening, and we have put them out there just because I feel it is kind of silly, but it is something that is entertaining to people, and at least it gets the messaging, and we have done that in English and Spanish. So that's part of it. Another part of it is to just kind of have doctors go and speak to community organizations and organizations like the American Cancer Society and volunteers that are doing some of the community navigation so that everybody knows about this. And so that's kind of the work that we have done on that end. But we need to grow more. And I think we need to kind of, we have so much work to do to make lung cancer feel like something that you will do every year. And I think patients don't think about that. They don't think about as a checkbox of another thing that I have to get done. So again, that was kind of something unique that we found, that we can kind of pivot from the use of internet and use of social media and social media networks in Hispanics to you kind of use that opportunity as a way to engage patients on the conversation.
Yeah, absolutely. Here at ALCSI, we're also trying to figure out how best we can use social media to share information as well. And one of our recent initiatives is working with mayors, governors, and state leaders to film public service announcements, very short 1-minute public service announcements that emphasize the importance of screening, talk about the screening criteria. And I think, as you had mentioned, like when approaching a community, I think having someone who is within that community, whether it be a state leader or someone that the community knows well and trusts, can really help with that messaging. And so that's something that we're working on within ALCSI, and we've seen a lot more engagement with our PSA videos than with some of our other tweets and other outreach strategies. So I definitely think that utilizing social media could be a great strategy. And I haven't heard of another organization using TikTok to share lung cancer screening information, which is very, very interesting. And so one question that we often get is, when we outreach to social media, especially through Instagram, the patient, or sorry, not the patient population, but the population that uses these social media platforms are oftentimes going to be younger individuals who most likely won't be eligible for lung cancer screening. And so the way we approached it is we have a +1 campaign where instead of asking people, are you eligible for lung cancer screening? We ask them, do you know someone who's eligible for lung cancer screening? So that opens up, and taps into their networks, whether it be like family members or friends, relatives who might be eligible for lung cancer screening. And so instead of we might not be able to directly reach the individuals who are eligible for lung cancer screening, but we're able to still get that information to them, hopefully. And so I wanted to ask, what is your marketing strategy or advertising strategy when you post about lung cancer screening through TikTok? Is it a similar like +1 campaign, or kind of how do you approach that?
I can show you the video, but it won't play on audio. But basically, we just picked a song and there was like a dance. It was like a flamenco of lung cancer screening. And then it just basically popped up with like the different criteria. So it was just supposed to be fun and kind of like get attention. But to your point, these are younger, you're engaging a younger audience. But for the Hispanic community in particular, where you have multi-generational families and people that live in the same household, and so in a way, though, the +1 campaign works very well for communities like that there's the young people are really engaging with the older generation in the same room. They're coming to the medical appointments. So it is kind of like a family affair. And we have done that in other initiatives. So we have targeted family members of breast cancer survivors about diet and exercise to get more breast cancer survivors to like concentrate on diet. So you have to kind of get more people engaged around you. The same thing with lung cancer screening. I think you have to kind of get the message out there. We have less smoking in the United States, but what people don't realize is that we definitely have more people being diagnosed because the peak of lung cancer in women, for example, and younger people that have either genetic predispositions or environmental exposures, those groups are going up. So really raising awareness about lung cancer screening for the people who are eligible is the first step, and then kind of going the next step about who's being missed by the current risk criteria. And I think you're right, like we have to kind of investigate different groups to understand what the risk is. And we see that because we have a very fluid immigrant community. So we may get there was 1 month that we got all these patients that came from one particular country with mesothelioma. And we were like, what's happening there? Like, it's just kind of like a very unique kind of epidemiology thing. And then you have people that have been here for a long time. Their smoking rates may be going down, but maybe the women in those households are the ones that have been exposed younger. So that those are the ones that you have to have a conversation with. The one thing that we would like to do next, which has been done in Vanderbilt, is really kind of tie in, because women are really the advocates for healthcare in their families. So Vanderbilt did a great program where they tied in lung cancer screening to mammogram. So they had this messaging of like, you can get both, or you should be doing both. But I think when they did that, not only they took an opportunity of something that women were doing all the time, but they actually targeted the most important person in that family to know about lung cancer screening. So I think that that's something that we want to grow in. There's another intervention that we're looking at survivors of bladder cancer, urothelial cancer. So people that will be at risk for lung cancer because they have similar smoking risk factors. So target them, because we do miss people who have survived one cancer and they got diagnosed with another one. So we recently had a fellow who just presented this, just looking at, what comes first, your lung cancer, your bladder, but you miss opportunities then. Like you could have had a woman who came from a mammogram was missed that could also have been screened for lung cancer, or someone who survived bladder cancer could have been screened for lung cancer. So all these missed opportunities are there, and we just kind of have to kind of put our brains together and kind of find ways to send the message out.
Yeah, and I think a lot of in recent years there's been a lot of great progress in terms of raising awareness about breast cancer screening, cervical cancer screening, colon cancer screening, these other cancers that are very common and well known. And I think if we can combine efforts for raising awareness for breast cancer screening with lung cancer screening awareness efforts, that can be really impactful, just as you had said. And so one thing that we've tried to do is work with breast cancer clinics to put up postcards on lung cancer screening, so offering that information about lung cancer screening when they come in to get their mammograms. And so as you had mentioned, Dr. Rodriguez, it's possible that patients who might be at high risk for one cancer will also be at high risk for another cancer, or who are already diagnosed with one cancer might be at high risk for another another cancer later on. And so just paralleling those efforts together could go a long way, as well as also combining efforts to increase smoking cessation. And so if we can get lung cancer screening information into smoking cessation centers, that can also go a long way. Since patients have told us that they were able to get lung cancer screening, but then there wasn't a clear connection to resources on smoking cessation, and so they had to kind of go out on their own to find the resources and smoking cessation centers near them. Whereas if we are able to make that connection and then bridge for them, that can go a long way. So if a person goes first to a smoking cessation center, they also receive information about lung cancer screening and vice versa. I think that can be very helpful as well.
Yeah. One thing that we haven't spoken about that I think a lot about, and trying to find ways to like make it operational, it's kind of the bias that goes into. So I think a lot about why if 5 patients came into a clinic and then the primary care doctor was very busy addressing like diabetes, high blood pressure, all these kinds of things, but then they chose to refer one patient. Like if you have 5 patients, they're all eligible. Who do they choose to refer? And then I think that's an interesting question, because there is some kind of bias from the provider perspective about things that are worth discussing with a patient, or patients that they believe will be, because there's this messaging of screening is tied to smoking cessation. I find that in a way, sometimes that hurts the programs, because there might be some kind of calculation that is made that, okay, this patient is really not going to quit smoking. Like maybe they're not the best eligible patient for a screening, when we should really separate the conversations, because they're 2 different issues. Because you can detect cancer early on a smoker and cure them just the same as someone who didn't want to stop smoking. And to us, the most important thing is to detect patients early. So I think the bias from the patient who doesn't want to inquire about lung screening because they think it's deadly and they don't want to talk about their smoking history, from the bias from the providers who are very busy, who choose to have these conversations that are easier with some patients and not others. And it's actually the patients that is the hardest to talk to, that take the longest time, that are actually the most impactful conversations that you can have. So I think that's something that we want to move into, and for that you need people who are experts in health decision making. And we have a group that does behavioral kind of research, because I think that we need to find ways for these conversations to become easier, and for these conversations to be prioritized the same way that diabetes and high blood pressure and other things are, because there's so many things that get discussed and there's so limited amount of time. The one thing that has really helped, and I don't know if you have had other people talk about telemedicine. So before COVID, when we were really struggling to kind of keep the numbers, and our program closed for about 2 months. So we were not taking screening programs because we were prioritizing other things. We learned that telemedicine was the best way to counsel patients that were being referred to the program. So we have gone from in-person appointments that were really a waste of time for patients, because we have a centralized program. So patients get referred. A physician cannot order a screening low-dose CT. They have to order a test for the screening program. And then that order goes to a navigator who then counsels the patient. So they used to have to come, meet the navigator, have a shared decision visit, talk about smoking cessation, and then be set up for an appointment. And now we're saving people time, and we get them on the phone, and we get them to agree, not agree. And we can also follow up a little bit easier, because like many cities, Miami has horrible traffic. You have to get a parking spot, and we we really lose people in the kind of logistics of coming in for another appointment. So telemedicine has really changed, really, I think, the landscape of what you can do for patients in these shared decision visits. And also, you know, at some point, these visits had to be given by a healthcare professional that was trained, but obviously these conversations can be given by anyone, and our navigators are well trained to do that. So, and that's also, I think, really important, because many of our primary care doctors feel that already they have so many demands and alerts on their time, that if you kind of take that work out of their workflow, so you say, you know, you just refer the patient and we'll take care of the rest. We'll make sure the patient gets followed. We counsel the patient, we refer them to smoking cessation. So we kind of take that conversation that takes time out of limited time that you have. So we're hoping that we can convince more primary care doctors that we do a good job of that. And it's a moving target. We have some providers, when we were reviewing clinics that refer really well and clinics that don't refer very well, we were looking at this question of bias and what's a competing interest. And we found that there's just some providers who are just very good at it. Like, they have made it part of their spill. Like, they just talk to patients about diabetes, hypertension, lung screening. So, and then some people do it better. So you have to train the new doctors to do it as well, and learn about the conversations that work and the conversations that don't work, and how you can really get patients to adhere to screening. So that's one thing. That another work that we have done is just looking at our adherence rate. And that's actually kind of unique, because if you compare to the National Lung Cancer Screening Trial that, when I was a fellow, was being done in Philadelphia, I remember, like, all those patients came back, like all those patients, like, and actually I will tell you, in the trial, it was like over 80% of patients came back. When we looked at our own data of adherence, we had a no-show rate for the initial visit of 26%. So a large amount of patients that were referred that never made it to that first visit, so they never got screened. And then when we looked at the patients that, once they got screened, came back for the next annual imaging, that was 31%. So a big drop from the National Lung Cancer Screening Trial. And this has been shown in other centers, that you lose patients through the process, and you kind of have to understand why, because if you don't do this test, you're losing an opportunity of people that were already engaged. And then we look to see, like, you know, what factors determine people that are adherent or not. So we found that for some reason, there was more adherence in men than women, which we thought was surprising, 22 to 19%. Like many things, married individuals have more support, so they were more likely to adhere to the next screen. And then we found actually that former smokers, more than former smokers who had quit, were more likely to adhere than current smokers. So Hispanics, like other groups in our database, were not coming back for the second screen as often as people did in the National Lung Cancer Screening Trial. So that's another thing, like, you know, people that even are in the system of your screening program, you lose them. And that's another area that we need to invest in.
Yeah, wonderful. Thank you so much, Dr. Rodriguez. I know that we spent a lot of time already talking about your screening program. So we do want to open it up to our audience Q&A now. And so if anyone in the audience has any questions, please feel free to ask your question by unmuting or by putting your question in the chat. We have received a question already, so I'll start off with this one. The question asks, is there anything that you would have done differently with your lung cancer screening program?
So we made our program centralized because we needed to make sure that everybody got counseling and got followed. But we have gotten pushback from providers that they feel that they should be able to order low-dose CTs that direct themselves. So one thing we will like to explore is, like, would that make a difference? Like, if people directly order the scan instead of having to refer them to a navigator that would order the scan. So that's something that we have to explore. Like I mentioned, like all these missed opportunities and bias of who gets counseled and refer for screening versus who doesn't. That's something that we need to educate more and kind of learn more about. And then the adherence, really the way to fix it is just having navigators. So we need to, you know, one of my complaints for our program, and something that I go to our leadership about, is that if we build it small, it stays small. So if you build a big program, like in Georgia, for example, they build a big statewide program. So they have a lot of numbers. that are kind of hard to replicate, but it was a state initiative, well-funded. They have many levels of intervention. They have many navigators, many facilities that were doing screening. So we need to grow. We need to have more centers that do screening on weekends, that do screenings at night. And we are getting there. Like we have about 8 satellites, about half of them can do screening. So we can do it closer to where people live, but still we're not capturing what we should capture. And, it's the kind of thing in when you get to the level of talking to administration, they always tell you like, show me the numbers, and then that you have a need, and then we'll hire more people. So it's hard to hire more people, but at the same time, if you have a navigator that only has a certain amount of capacity, then that kind of limits the amount of people you can put in every month. So that's something that we are working actively on conversations to try to automate it. So there are programs that have completely automated pulmonary nodules so that people get screened based on like any nodule, although that gets identified, they get referred for follow-up. So there are different ways of finding patients that don't require doctors' interface. And I think that's kind of our next level of how we find patients directly without having to go through the navigator referral process.
So for the next question we received, it is, what has been the most memorable patient case for you?
So, I mean, I'm always, I think I have patients that have been followed through screening that, it's so rewarding. I mean, we don't pick up that many lung cancers. So in our whole program, we have picked up probably around 20, but most of them have been, I get 90% of them have been early stage, which is the good news. So I get the memorable stories is the people that get screened and you find something and you cure it. And there was a patient that was kind enough, who actually was someone that worked in the staff of the university, who was a Cuban man who smoked when he first moved to the country and had stopped. And he was having a conversation with his primary care doctor, and they referred him to the program. And we were able to detect something. And it always was memorable to me because these were people that, this is someone that worked for us, like they worked with me, and they were right there with a pulmonary mass that needed to be found. So that's very memorable because I think that if we're missing the people kind of next to us, like we're missing everyone. So that was one story. And then, we always meet people that incidentally got diagnosed with lung cancer. So people that had coronary, like they had a scan for coronary calcifications, and then they get found to have a nodule. I have all these patients that have had back pain, car accidents, and they get found with things, but they're like the lucky few. And the whole point of screening is that it shouldn't be the lucky few that get found with lung cancer, that it should be everyone who has something there growing. But yeah, that was one story that stayed with me. And he actually was kind enough to share his story on the news. And we did a piece because we do a lot of things with media to kind of share the story, because people remember stories, they don't remember numbers. So we told his story, the fact that he was here in the university, and he told us about when he started smoking very young in Cuba, when he was like in his teens. And how when he quit and how he felt about it, and how lucky he felt that, he was cured from cancer. Yeah.
Yeah, that's wonderful to hear. Thank you for sharing those stories. Our last question is, how do you think the lung cancer screening guidelines need to change to reduce disparities in lung cancer screening?
That's a great question. I think that I think that we are doing better by starting almost everything at 50, because then that's a time that you're having other conversations with patients. So like you're talking to them about colorectal cancer, you're talking to breast cancer screening in their 40s. So I think that it could even be younger for people that you find have had at some point, we can able to detect exposure. Like if people have been exposed to secondhand smoke in a significant amount, then we'll be able to screen those and add that into the mix. I think there are other things that increase your risk that don't get included, like COPD and patients that have been in immunosuppressive therapy. So there's a lot of other caveats to people that may be at risk that get missed. I would love to see lung cancer screening kind of mapped out, by community. So, there's these big maps of availability of screening programs and where the high risk smokers are, and how these two things don't correspond. Like there's a big part of the United States that has rural communities that have heavy smokers and no lung cancer screening program nearby. And the same thing happens in a in our own smaller communities. Like we have lung cancer screening programs, but we may have people from the Keys that have to drive, an hour and a half. Or we might, I think the one thing that screening programs will also have to take into account are kind of like, what are the barriers and what are the smoking rates in different communities that are at risk, that are not getting access. So I think that that's another level of screening outreach that is not really accounted for. So besides taking into consideration other comorbidities that increase your risk, I think that the risk stratification could be better, and we might find that there are ethnic groups that need even younger ages to be screened. But we also need to kind of find people where they are. And I think that we have the ability to do that. If we can map patients better, we can then intervene better. If we know that this is where all the smokers are, or like communities that are higher risk, then we could really put our efforts there more.
So that was the last question we received, and that concludes our podcast. So we would like to thank you again, Dr. Rodriguez, for your willingness to share your wealth of knowledge and perspective on many of the pressing issues in the lung cancer world, especially in the Hispanic community. We appreciate all the work and research you are currently doing. And thank you everyone for listening to our podcast. Please keep an eye out for our upcoming podcasts and events, which will be listed on our website, www.alcsi.org. This week we have podcasts with Dr. Molshine and Dr. Emily Stone. Zoom registration and information on these individuals can be found on our website under calendar events or on our Instagram bio. Thank you everyone, and have a great day.
Thank you.
Thank you so much, Dr. Rodriguez.
Okay, thank you. Bye-bye.